Good day to you all. My name is John Mendy. I'm a student of Maryville University, and today I'll be having a presentation on my Doctor of Nursing Practice project titled Agency for Healthcare Research and Quality Coordinated Spontaneous Awakening Trial and Spontaneous Breathing Trial Checklist Implementation in the Medical Intensive Care Unit to reduce Ventilator-Associated Pneumonia. Throughout this presentation, I'm going to be using some of these acronyms like AHRQ, SAT, SBT, MICU or MICU, VAP as well. So the AHRQ stands for Agency for Healthcare Research and Quality, SAT for Spontaneous Awakening Trial, SBT for Spontaneous Breathing Trial, MICU or MICU is for Medical Intensive Care Unit, and VAP is for Ventilator-Associated Pneumonia. This project focuses on improving the safety of mechanical ventilated patients through better coordination of spontaneous awakening trial and spontaneous breathing trial. By integrating an evidence-based checklist from the Agency for Healthcare Research and Quality, the MICU team aimed to reduce the incidence of ventilator-associated pneumonia and improve overall clinical outcome. I have Dr. Rachel Davis Cintron as my chairperson, Dr. Maria Snell, and I also have my community member, she's Dr. Beverly Collins. Now, I want to say that my chairperson of Dr. Rachel Davis Cintron have been a big role in ensuring that I gain success in this program. As she will say, John, you can do it. Background and significance. Ventilator-associated pneumonia increase morbidity and mortality. Ventilator-associated pneumonia remains one of the most preventable yet persistent complications among adults requiring mechanical ventilation. It is associated with increased length of stay, higher healthcare costs, and greater mortality risk. That's according to CLOMPAC of 2022. So before I continue on with this presentation, I want to make my audience understand what this project is all about. We have the spontaneous awakening trial. This is the situation, this is when the nurses go in to approach the patient trying to turn down sedation. The goal is to walk towards extubation, which is trying to take the tube off the patient's airway and hoping that the patient will be able to breathe by themselves. So when a patient is intubated, right from the first day of intubation, the goal is to extubate the patient. The goal is to make sure that the patient regain their respiratory drive and be able to breathe by themselves. In this case, a nurse will have to approach the patient, turn down sedations, and watch to see if the patient will be able to tolerate that. Some of the things the nurse will be looking for is the vital sign, ensuring that they are stable, The nurse will also be trying to see if the patient can follow command, and if the patient can follow command, of course, and less agitation. Of course, the nurse will work with the respiratory therapist, whereby the respiratory therapist will come and place the patient on a spontaneous breathing trial, which means the respiratory therapist will have to come in and put the vent settings on a spontaneous settings, whereby the patient will try to initiate breath by themselves, try to breathe by themselves with no much labor breathing, or change in vital signs, agitation, or more confusion. So the goal is to be successful and work towards extubation. The goal of this project, which we just talked about, was to standardize the SAT-SBT workflow using this AHRQ checklist, which emphasizes organized communication between nurses and respiratory therapists. Evidence shows that structural awakening and breathing strategies shorten ventilator time and reduce the effect of infection risk, according to Levinson. Review of system. The literature supports the use of standardized checklists to improve clinical reliability in critical care settings. Checklist helps reduce practice variation and enhance team coordination. Studies demonstrate that consistent SAT and SBT practice lead to fewer ventilator days and improved extubation success. According to the Agency for Health Research Quality, research highlights that poor communication between nurses and respiratory therapists is a common barrier to successful implementation. When teams adopt coordinated protocols, outcomes improve significantly, particularly with respect to ventilator-associated pneumonia reduction. Theoretical framework. The Iowa model of evidence-based practice guided this project. This framework encourages clinicians to identify a problem, evaluate supporting evidence, and integrate an intervention that aligns with patient needs and organizational priorities. The model helps structure each phase of this project, from identifying inconsistent SAT/SBT practices to evaluating outcomes after checklist implementation. By using the Iowa model, the project remained systematic, collaborative, and focused on translating evidence into bedside practice. Methods and design. A quantitative pre-post design was selected to evaluate changes before and after checklist implementation. Data were obtained through a retrospective chart review of MICU patients requiring mechanical ventilation. The intervention involved implementing the AHRQ coordinated SAT/SBT checklist over a 12-week period. The checklist facilitated structured communication and enhanced that both the nurse and respiratory therapists evaluated the patient collectively each day. This design allowed a direct comparison of ventilator-associated pneumonia rates, compliance percentage, and ventilator days. Example. The project includes adult MICU patients who require mechanical ventilator during the designated time frame. Data from January through June 2025 were used as the pre-implementation sample, while data from July and August 2025 represented the post-implementation sample. This sample reflected a typical MICU ventilated population and provided a meaningful basis for evaluating patient outcomes after checklist adoption. Data analysis. Data were analyzed using descriptive statistics and a z-test for two proportions to compare pre- and post-intervention VAP rates. Interactor reliability was assessed between us and respiratory therapists using a checklist, resulting in strong reliability coefficient of 0.94. This analysis ensured accurate measurement of intervention impact and validated the consistency of documentation among team members. Results. The results show significant improvement following checklist implementation. VAP cases decreased from 16 to 2 and 87.5 reduction. SAT/SBT compliance improved from 47% to 91%. Ventilator days decreased from 7.2 to 4.3 days, representing a 40% reduction. The z-test confirms statistical significance with a p-value less than 0.1. Interactor reliability demonstrated high consistency between team members. This outcome indicates that the AHRQ checklist not only improved workflow, but also contributed to meaningful clinical improvements. See the bar chart that represents the result. In this bar chart, we see that there are the pre-VAP of 16 patient cases reduced to 2 post-intervention. We can also see this bar chart that represents the SAT/SBT compliance improvement. We can see that the improvement pre-compliance from 47% made an improvement post-compliance of 91%. That is to tell you that this AHRQ checklist that was implemented in this unit yielded a good result, yielded nurses turnout, and so therefore reduced the number of incidents of VAP. Limitations. Several limitations are noted. The post-implementation period was relatively small. It was for a short period of time. Hoping that this project had enough time to improve, to carry out this research, this implementation, and see how it can make improvement or impact across the board. As with any retrospective review, documentation reliability could influence the accuracy of recorded data. Despite these limitations, the findings provide strong support for continued use and broader adoption of this checklist. Discussion. The findings of this project demonstrate that structured SAT/SBT coordination significantly improve compliance and patient outcomes. The reduction in ventilator days align with national recommendations, suggesting that early awakening and breathing assessment enhance ventilator liberation. This project also strengthened team communication, which has been identified as critical component of successful critical care intervention. Overall, the result reinforced the importance of standardized evidence-based checklists in preventing complications. Implications of practice. This project highlights how implementing a structured process can directly improve patient safety, increase SAT/SBT compliance, reduce time on ventilator, decrease complications such as VAP, and enhances recovery. The checklist can be incorporated into daily workflow, orientation materials, and electronic medical records. Expanding this intervention across other ICU may create organizational consistency and further improve patient outcomes. In my conclusion, I want to also strongly point that the AHRQ SAT/SBT checklist led to measurable improvement in ventilator case and VAP reduction. Moving forward, further expansion, continuous staff reduction, and ongoing monitoring will help sustain this improvement. Continuous staff education and ongoing monitoring will help sustain this improvement. This project has also influenced my professional development by strengthening my evidence-based practice skills, leading abilities, and confidence in leading system-level change. The DMP program provided the foundation to translate evidence into practice and achieve meaningful improvement in patient care. I want to use this opportunity to thank every member of this department. I want to thank every member of my community, Dr. Citron, Dr. Snare, Dr. Collins, and I want to thank my audience and the committee for giving me this opportunity to carry out this research and listening to my outcome. God bless you and have a good day. Thank you for taking the time as well, hoping that we can reduce the incidence of ventilator-associated pneumonia through the implementation of this AHRQ checklist, that our nurses will be able to improve their compliance rate, so therefore reducing this preventable infection both within the ICU, the medical ICU, and across other intensive care units where patients are being cared for, by providing them with the life support. Once again, thank you and God bless you.